Episode 1 of My PA Notes, your Ultimate Physician Associate podcast. In today's episode, I want to talk about essential hypertension. I'm going to explore definition, causes, pathophysiology, risk factors, symptoms, diagnosis, and management. And hopefully at the end, I would like to go through some MCQ questions and provide some revision tips. So let's get started. Alright, welcome back again, my fellow PA students. I'm your host, Martin Sisufu, and the founder of My PA Notes. And like I said before, we're going to go through some topics about essential hypertension. Hopefully we can get some greater understanding, and let's just get on with it. So if you head on to my website, which is obviously mypanotes.co.uk, and if you click on the blueprint tab, either through the topic or the cardiology, and you'll be presented with a list of options. And the first condition of the matrix of condition will be essential hypertension. I've got a video on my YouTube channel which covers hypertension, but it tends it kind of like cover all type of hypertension, and it's quite an old video now. So again, I wanted to start with this new podcast, so see how that goes for today. So if you want to click on that, that's good, but I'm probably going to replace it with this podcast episode. But if you want to watch the old one, obviously it will still be on the channel, but it will not be on this main bit. So let's scroll down in my website. So as you can see, it says cardiology 12%, which is the core clinical condition. So the percentage represents the weight of each module or subject for the single best answers, which is the SBA. So it starts from 12% down to I think 5%. I'm not too sure, but yeah. So basically, you're likely to get cardiology questions at the nationals. Doesn't mean the other ones won't be there. It just simply means that you're likely to get cardiology. So, and on top of that is a 1A condition. So a PA should be able to diagnose and manage this kind of patients. In my current post, I am the hypertension lead. So I see a lot of the hypertension patients. So I have to be very familiar with essential hypertension. You know how to manage the patient, diagnose, refer, and so forth. So what I'm trying to say, you have to be very comfortable with diagnosing and managing hypertension. So I've got several hyperlinks on my website. So we're just going to go through them step by step, and hopefully you can get some better understanding about essential hypertension. So the definition of essential hypertension, it can be defined as a blood pressure reading of 140 over 90. I would say same or equal or above, with no known secondary causes. So nobody know really the cause. Everything's pretty okay, but they do have high blood pressure. Now it's important to understand the etiology, which is a fancy word for causes. And there's several factors involving obviously the etiology. Obviously it's high salt intake. This is mainly true in highly processed foods. So if a patient has a poor diet, most likely they will have excess salt intake. Do we have high level of smoking, obesity? So they do pack a bit of risk factors. Sedentary lifestyle, aging, which is true. Your blood pressure tends to rise as you get older anyway. So that is also a common cause. Renal sodium retention, so that's the kidney retaining more salt. Insulin resistance, high alcohol intake, smoking, and low calcium, magnesium, potassium intake. So it's basically poor diet all over again. And there's obviously, if you have a family history of high blood pressure, they are likely to have high blood pressure themselves. Most of my patients that I diagnose with essential hypertension, they do come from a family history of high blood pressure. So it's important for you to know that when you're revising. So moving down to the pathophysiology. Well, there's a lot of jargons here. I try to make it as simple as I can, but it's difficult. So I'm going to probably have to reward it from the website. The short version will be there's a physiological balance between the arterial baroreceptors, the renin-angiotensin-aldosterone system, which kind of involve your kidneys and stuff like that. Your atrial nitriuretic peptide. Oh my God, these are crazy names. So basically what I'm saying, there's an imbalance in the normal physiology of how your body regulates your blood pressure. So there's a dysfunction. And when there's a dysfunction, obviously it causes high systemic vascular resistance, increased cardiac output, and over time, the blood vessels themselves become less flexible, more rigid, which limits vasodilation, and obviously vasoconstriction follows up, rising your blood pressure. Yeah, I'll need to work on this when I work back on the website. Try to make this a bit more simple. But this was one of the first condition I covered on the website, so just bear with me. I will try to improve that. So what are the common risk factors? It's very similar to the etiology anyway. High salt intake, about 1.5 grams per day. It's quite a lot, but you have a couple of burgers, there you go. You've got enough to achieve this, really. Obesity, being overweight, obese, increases the chances of getting high blood pressure. Not necessarily, but it is something to be aware. And obviously, poor diet, aging, and ethnicity, again, is linked to genetics. Black Africans and African Caribbeans descent are more likely to develop high blood pressure. And if you have already underlying health conditions such as chronic kidney disease, diabetes, that was my chair, it's a bit squiggly, and sleep apnea. This is quite interesting. Sleep apnea has been linked to a lot of conditions, so it's not something to be taken lightly. All right, so let's move to signs and symptoms. I would say most people are asymptomatic, and that is why it's called the silent killer. However, some of the common symptoms which patients tend to present when the blood pressure, I would say, is about above 108, really. They may present with headache, chest pain, shortness of breath, visual disturbances, and dizziness, and other symptoms. But once you check their blood pressure, you will have an idea. So moving on to the investigations. Investigation diagnosis. So you want to start an investigation with bedside tests such as a urine dipstick or urine test, check for hematuria. You want to do the urine albumin creatinine ratio. You can request some blood tests, things like HbA1c, use and ease, cholesterol, lipids is important. If you are able to do a fundoscopy, you will notice if the patient does truly have high blood pressure and you're suspecting an organ damage, then obviously you can perform the fundoscopy, look in the back end of their eyes. If you're unable to perform fundoscopy, obviously you can refer the patient to the optician, and they should be able to help you with that. I think most places have a eye service, community eye service test, so you can refer the patients there. Obviously, if you are really worried, you can tell them to go to the hospital. Then you have your classic diagnosis, which is a 12-lead ECG, which will assess for cardiac function. And normally you will also want to request a Q risk and assess the need for statin, but that could be something on top of the main presentation. All right, so moving to the diagnosis, an investigation again. Now, like we mentioned before, if the blood pressure is above 140/90, now if a patient presents with 140/90 in clinic, it doesn't mean that they have hypertension, but you need to have a high suspicion and they need to arrange the diagnosis. Now, the easiest way would be to do a 24-hour ambulatory blood pressure, but it depends on your clinic, where you are. If in the hospital, that can be quite tricky because the patient has to be on it for 24 hours. It's difficult to arrange that. Most of my patients, I tell them to purchase a blood pressure monitor, a blood pressure machine. And then over 7 days, they can bring back the recording. And if the recording at home is above 135/85, that is a clear diagnosis for hypertension, especially if there's no other causes. And then you can manage the patient appropriately with diets or medication. So it's important for you to understand different stages of hypertension, because this question tends to occur during the SBA. It's quite obvious. You can easily overlook this stage. So just be aware, stage 1, your classic home blood pressure, 140/90. Stage 2, if the blood pressure is above 160/100, similar at home, 150/95. Even though on the website I say ambulatory, it's the same thing really. And stage 3, hypertension, home or clinic, anything above 180/120, you need to have a high suspicion of anything more sinister. If the patient is having severe symptoms, they should be admitted. Now, as a PA, you should be aware of these medications. So your ramipril, which is your ACE inhibitor, your ARBs, which is like losartan, candesartan, your calcium channel blocker, which is amlodipine, nifedipine, and so forth. Your diuretics such as indapamide, bendrofurosemide, something like that. Your alpha blocker, doxazosin, and your beta blocker, bisoprolol. Now, the beta blockers are not really used to manage hypertension unless a patient is female, around the age of being able to get pregnant, and then they may consider blood pressure tablets, but it's not bisoprolol. I think it's lobetalol. I think you can check in your local guideline to be sure about that, but that is a different case scenario. Yeah. Now, it's important even as a student to know about the stepped approach. So I tried to make it a bit simple on my website, but I've got the visual one from the NICE guideline. So if you scroll down, it's basically summarizing what we're talking about. So you can just go on the website. So basically, if a patient has hypertension without being type 2 diabetic, you need to consider the following. So if they're less than 55 and not of Black African or African Caribbean origin, you need to start them on an ACE inhibitor or an ARB. Okay, and we discuss ACE inhibitors like ramipril. Okay, ARB like candesartan, losartan. Okay, and that will be your step 1 if they're less than 55 and not Black or Afro-Caribbean. If they are Black or Afro-Caribbean of any age or age 55 or over, they have to be started on the calcium channel blocker. There were some studies done basically that calcium channel blocker work better with this population. You can go and read about it online. I'm not going to dive into that, but it's quite an interesting study. Okay, then the second step. So I'm just going to go back to the not African less than 55. You need to basically add. Okay, so it's important to know that the patient cannot be on an ACE inhibitor and an ARB at the same time. Okay, so if they are on Ramipril, you cannot go and add a second line losartan, vice versa also. Okay, so if they're, for example, on an ACE inhibitor, the blood pressure is still uncontrolled in the less than 55 and not Afro-Caribbean or African, you add a calcium channel blocker or thiazide-like diuretic. Calcium channel blocker, which means like amlodipine, and thiazide-like diuretic like indapamide. And if the patient is above 55 and or black of any age, obviously you started them on a calcium channel blocker, and you will need to add an ACE inhibitor or a ARB, or again a thiazide-like diuretic, and that will be your step 2. Now it's a bit difficult to follow if you're listening, but hopefully if you're on YouTube, you can actually visually see it and visually watch it, and hopefully this will help you. Now the step 3 is what we call like a triple therapy. So they're on ACE inhibitor, and that is common from both. It doesn't matter if they're Afro-Caribbean or not, any above 55 or not. If they're already on the step 3, so they will be on ACE inhibitor or an ARB plus a calcium channel blocker plus a thiazide-like diuretic. Now, I don't have too many patients on this, but you can find some complex patients that, you're starting to get a bit worried when the blood pressure is not managed at step 3. At step 4, you need to confirm that they're treatment-resistant hypertension. So how would you do that? I normally tell them to do a home blood pressure reading for 7 days at home and wait for the results. Because sometimes when you check the blood pressure in clinic, you're adding medication, but the blood pressure is just raised in clinic. So you can kind of like tone down, and there's nothing wrong going back to step 2 or step 1 if you're being too proactive in managing the blood pressure. The last line will be basically to consider adding a low dose spironolactone, but obviously you have to be mindful of the potassium. So if the potassium level is less than 4.5 millimole per liter, then a low dose spironolactone might be appropriate. If their potassium level is above 4.5 millimole per liter, then alpha blocker might be more appropriate, or a beta blocker. And like I said, if you're already on step 4 and you're convinced you're 100% certain that the patient has treatment-resistant hypertension, what I normally do, I just seek expert advice, and all the cardiologists or the hypertension clinic, they're very happy to help you. That helps you as a clinician, that helps the patient, and everybody's happy. Okay, so that will be the gist for hypertension, at least up to now in 2023. Things may change obviously in the future, but yeah, that will be the main gist for hypertension. I've got my own summary on my website, so if you click on this link, on the Access Now link in the Essential Hypertension part of my website, it will take you to where you can download a free copy of a summary I made of what you need to know for your nationals, or what you need to be aware of in regards to hypertension. All right, now, so let's move to the MCQs. All right, so question number 1: what is the blood pressure reading that qualifies has essential hypertension? This should be quite easy. 140/90. Which of the following is not a risk factor for essential hypertension? So we've got several options. Sedentary lifestyle, B for excess salt intake, C for genetic predisposition, D low potassium intake. So which is not a risk factor for essential hypertension? You can go ahead and pause this video or pause this clip if you are listening in your car. So A for sedentary lifestyle, B for excess salt intake, C for genetic predisposition, D for low potassium intake. The answer will be D, low potassium intake. That is not a risk factor for essential hypertension. Now, let's move to number 3. Number 3, which physiological processes are involved in the pathophysiology of essential hypertension? Now, this is a handful. A for arterial bioreceptor and renin-angiotensin aldosterone system. B for atrial natriuretic peptide and mineralocorticoid hormones. C for endothelins and glucocorticoid hormones. D for all of the above. No way I'm going to repeat that, guys. So if you want to just rewind, go for it. I am not repeating that mouthful. I've got dyslexia, so I am not doing that. So what is the answer for that? B. Again, I'm not repeating it. Just rewind. Just re-listening to it again. Number 4. Which symptoms may be experienced by an individual with essential hypertension? A. Fatigue and muscle weakness. B. Nausea and vomiting. C. Headache and chest pain. D. Blurred vision and hearing loss. Again, this is a short best answer example, so you need to think like what the examiners may ask. And what is the correct answer? C. Again, most patients are asymptomatic, but most patients present with headache and chest pain symptoms. Mainly headache, I would say. Moving to number 5. Which diagnostic investigation is used to assess cardiac function in patients with essential hypertension? A urine test for hematuria. B. Blood test for cholesterol levels. C. Fundoscopy for hypertensive retinopathy. D. 12-lead ECG. The answer is 12-lead ECG. All the other ones are good diagnosis, but it answers the question. So that's the trick about SBAs, okay? Always read the question properly, because all of these ones were right, but only one answered the question. So let's move to number 6. What confirmatory measure is commonly arranged to diagnose hypertension? Urine albumin to creatinine ratio. B. Blood pressure measurement at a clinic. C. 24-hour ambulatory blood pressure monitoring or home blood pressure monitor readings. D. The Q risk assessment for cardiovascular risk. Which one do you think is the answer? They're quite simple, so the answer is C. 24-hour ambulatory or the home blood pressure reading over 7 days, like we just discussed. Number 7. Which medication is the recommended first-line treatment for hypertension in patients of Black African or African-Caribbean ancestry. So we literally just covered that. So A, ACE inhibitor. B, calcium channel blocker. C, thiazide diuretic. D, angiotensin receptor blockers. B, calcium channel blocker, because that is the first line treatment for Afro-Caribbeans or Africans. So if you're not too sure, you can rewind this episode, or just go straight to my website, or go to the Nice Guy Learn. You've got different ways to find the answer, but it's important you know that calcium channel blocker would be the answer. So which step of management approach should be considered if hypertension is not well controlled with an ACE inhibitor or ARB alone? A, step 1. B, step 2. C, step 3. D, step 4. It makes sense only if you've listened to the episode. Yeah. So the answer would be step 2. You want to carry on. If the patient, depending obviously if the Afro-Caribbean, in this case, is most likely not Afro-Caribbean, so you want to add a calcium channel blocker or a thiazide-like diuretic. Which medication may be added if hypertension remains uncontrolled after step 1, 2, and 3 of the management approach? A, an alpha blocker. B, a beta blocker. C, a diuretic. D, spironolactone. So you're basically going to step 4. A diuretic. That will be the answer. Is it step 4? It's probably step 3, really. Yeah. Oh, sorry about that, guys. My glasses keep hitting the microphone. Blunder. And the last question. What is the primary goal of managing hypertension? A, to normalize blood pressure levels. B, to eliminate all risk factor. C, to reverse the genetic predisposition. D, to treat the symptoms associated with hypertension. Obviously, to normalize blood pressure levels. I don't think we're trying to reverse all risk factors. It's impossible to reverse the genetic predisposition and to treat the symptoms associated with hypertension. I don't know. What are you trying to treat? Maybe headache? I don't know. Yeah. So anyway, this is just a snippet of possible MCQs. I know they're quite simple, but it's always the simple stuff that catches you off guard. All right. So we're coming to the end of this episode. So before we move on, I've got some revision tips I would like to share with you guys to be able to effectively study and learn what you need to know about hypertension. So the key definition is always know 140/90 is a definition for the diagnosis. Okay, but on top of that is for you to know that is high blood pressure of 140/90 without an identifiable secondary cause. Okay, so another tip, I want you to be familiar with the investigation for hypertension. Like we mentioned, your urine test, urine albumin to creatinine ratio. You want to be aware of the blood test request, even though it might not be related to hypertension himself, but especially your use and ease if the patient have low EGFR, which is the actual kidney function itself, then you need to be suspicious of all the diagnosis. And if the EGFR is normal or low, it will have an influence on the type of medication you can start as a PA or request to your normal GP. Fundoscopy is very important, especially for hypertensive retinopathy. ECG being the main one, and being aware of the Q risk. Normally, you would consider starting a patient if their Q risk is above 20, but sometimes you may consider that if they are diabetic, you may consider also starting when the Q risk is still about 10% or below that. So it depends on the patient. So have a grasp of the diagnosis and staging. So like I said, stage 1, be very aware of it, that if the blood pressure is above 190 over 140 over 90, that's stage 1. Stage 2, 160 over 100. Stage 3, 180 over 120. Because at the national, they may catch you off guard with these questions and then just say which one is stage 1, and they give you 180, and you know stage 1 is 140 over 90. Just try to keep that in mind. And again, be familiar with the medications that are used for the treatment of hypertension. I'm just going to go through them again. Your ACE inhibitor is always your Ramipril. There are different ones, but at the national to be the common one, which is Ramipril. Your ARB, which is your losartan. Sometimes it might be also candesartan, but those are the two ones that tend to occur as a question. Your calcium channel blocker will be mostly amlodipine, but sometimes they may also be nifedipine. Diuretic, indapamide, which is the first line. Alpha blocker, which is doxazosin, and your beta blocker, which is your bisoprolol. Okay. If you're familiar with these things, you're aware of all these things we mentioned, you should be fine at the national, and you should pass your single best answers without any problem. All right, fantastic. And there you have it. I hope in this episode I explored all the bits and pieces you need to know about essential hypertension. We've covered definition, causes, risk factors, diagnosis strategies, and management. Remember, knowledge is power. And hopefully in the next episode we will be able to cover the next condition on the list. And if you do have any questions, do leave a comment below. And if you have any more interesting thoughts and you want to present to me, just leave a comment below, really. Don't forget to like and subscribe. And I'll see you guys in the next one. And check out my website, which is mypanotes.co.uk. See you guys in the next one.